welcome to the deep dive. For decades, that painful, gnawing sensation of a stomach ulcer was blamed on. Well, everything from your high-stress job to that extra spicy vindaloo.
Right, the narrative was so simple. It was a lifestyle choice. Stress, food.
Exactly. But modern medicine has it's completely flipped the script. We are diving into Peptic Ulcer Disease, PD, to show you why that old, simplistic view is utterly history. It's now dominated by two things: the common bacterium and the pain pills in your medicine cabinet.
That really is the core of it. PUD is common. It affects millions, but the science behind it is surprisingly complex. Today, we're going to move way past the stress theory and give you a clear, actionable understanding of the microbial and pharmacological realities.
Okay, so what's the plan?
We're going to define what this break in the lining really is, discuss the profound paradox of the silent ulcer, the one that offers zero warning, and most crucially, we're going to reveal why the global medical strategy for treating the leading cause, that bacterium H. pylori, has just undergone a mandatory and frankly radical overhaul based on new 2024 guidelines.
So our mission today is critical for any learner: to understand how modern medicine diagnoses a breach in that mucosal lining and why the rise of global antibiotic resistance has made these new eradication strategies just absolutely paramount.
Right, so to start, let's be really clear about what an ulcer even is. If you just have some superficial irritation, that's what we call an erosion.
Not a true ulcer.
Not a true ulcer. A peptic ulcer is defined as a break in the stomach or duodenal lining that is deep enough to extend through the muscularis mucosae. That's a key protective layer. And it's usually defined as being over 5 millimeters in diameter. It's a literal hole in the lining.
And these holes are incredibly common. In the U.S., we're talking about roughly 500,000 new cases every year.
Plus an estimated 4 million ulcer recurrences. It's a condition that medical professionals see constantly.
And these breaks, they show up in very predictable places, right? Which helps narrow down the cause.
Exactly. We basically have two types. First, you've got duodenal ulcers, or DUs. These are the most common, and they tend to affect a younger demographic, usually between 30 and 55 years old.
Okay.
And the vast majority, we're talking over 95%, are located right where the stomach empties into the small intestine, in the duodenal bulb.
Then you have gastric ulcers, GUs, which are actually inside the stomach itself.
Precisely. Gastric ulcers typically affect an older population, generally 55 to 70. They tend to cluster in the lower part of the stomach, the antrum, about 60% of them, or at the junction where the antrum meets the main body of the stomach.
And that division, that age and location difference, that's our first massive clue about the root cause.
It's a great pivot point, because if you look at the total pool of peptic ulcers worldwide, 75% of them are accounted for by just two factors.
The bug in the pill.
The bug in the pill, the chronic lurking presence of H. pylori, and the widespread use of non-steroidal anti-inflammatory drugs, NSAIDs.
And this creates a really fascinating trend when you look at the data over time.
It does, because we've actually gotten very successful over the last 30 years in screening for and eradicating H. pylori. And because of that, the incidence of duodenal ulcers has declined dramatically.
So we're managing the microbial side of it pretty well.
We are, but surprisingly, the incidence of gastric ulcers, that has not declined. It's held steady.
And that's the pill side of the equation.
That persistence is our pharmacological side effect. It's driven primarily by the ongoing, massive, often over-the-counter use of NSAIDs and low-dose aspirin, especially in that older population that needs pain management.
Okay, let's put a spotlight back on H. pylori for a second. It's a necessary cofactor for the vast majority of ulcers that aren't caused by NSAIDs. If a doctor diagnoses a duodenal ulcer, they're expecting to find this bacteria.
Oh, absolutely. The prevalence is somewhere between 70 and 90% in those patients. And the success story of eradication is just remarkable. If you leave H. pylori untreated, something like 85% of patients will have their ulcer recur within a year.
Wow.
But after a successful antibiotic course, that recurrence rate plummets to just 5 to 20%. And most of those remaining recurrences, you can trace them right back to NSAID use.
What's so fascinating here is how the same bacteria can cause two different types of ulcers in two different ways. It's not a one-size-fits-all mechanism.
It is absolutely not. So think of the stomach lining as a fortress wall, and the antrum, that's the lower stomach, as the control room for acid.
Okay, I'm with you.
In duodenal ulcer patients, H. pylori sets up shop in the antrum, in the control room, and that infection leads to increased acid secretion. It's like the control room is stuck on full blast, and all that extra acid causes problems downstream in the duodenum.
High acid downstream damage. Makes sense.
Now, for gastric ulcers, the bacteria are usually found in the gastric body on the fortress wall itself. Here, the infection doesn't really increase acid. In fact, it might even decrease it.
So what's the mechanism?
Instead, it's just that the chronic inflammation and the bacterial presence overwhelm the physical defenses of the mucosal lining, causing the breach directly in the stomach wall. The acid is less the weapon and more collateral damage in that environment.
It is a phenomenal distinction. Same bug, different mechanism, different ulcer.
Yeah.
So let's talk about detection, because we said epigastric pain dyspepsia is the hallmark, that gnawing, hunger-like feeling.
Right, present in almost 90% of patients. But here is the paradox we promised.
It's a big one.
The paradox is that the pain is utterly unreliable. Less than 10% of patients who come to the doctor complaining of dyspepsia actually have a true ulcer that you can see on an endoscopy.
So relying on pain means we're missing a huge number of people.
And we're also overdiagnosing simple irritation, which leads to the critical clinical insight, the thing you really need to internalize. 10 to 20% of patients who present to the hospital with a major ulcer complication, like internal bleeding,
Serious event.
a life-threatening event. They have no antecedent symptoms. They were completely unaware. They are presenting with a silent ulcer that has suddenly become a crisis.
And that silence is even more pronounced if the cause is NSAIDs.
Oh, much more. The sources show that nearly 60% of patients who experience major complications from NSAID-related ulcers, the ones caused by those over-the-counter pills, had absolutely no warning signs beforehand.
So they're just taking a common pain reliever.
And the damage is just occurring silently right beneath the surface.
That's terrifying. So given that symptoms are so unreliable, what is the definitive way to diagnose this?
Upper endoscopy is the procedure of choice. It lets us see the ulcer directly, and there's a vital diagnostic distinction based on location. Duodenal ulcers are virtually never malignant, so we usually don't need a biopsy. Gastric ulcers, though, are different. About 3 to 5% of them are malignant.
That's a huge difference.
It is. So if a doctor sees a gastric ulcer, it requires an immediate biopsy to rule out malignancy. And if that's inconclusive, the patient has to come back 8 to 12 weeks later to document complete healing. If it hasn't healed, you have to be highly suspicious of cancer.
So we've got the bug, the pill, the silent threat. This brings us right to the revolution in treatment. If H. pylori is the most common cause and antibiotic resistance is soaring, what used to work must now be failing.
That's exactly the crisis we're in. The old standard was what we called PPI clarithromycin triple therapy. You might know it by the trade name Prevpac.
Sure, I've heard of that.
It was the champion for decades. But resistance to two key antibiotics in that cocktail, clarithromycin and levofloxacin, is now routinely exceeding 15 to 20% in most parts of the world. And once resistance hits that level, the treatment success rate just plummets.
So the standard triple therapy, which has been the default for 20 years, it's dead.
In terms of first-line empiric treatment, yes. The 2024 guidelines mandate a never rule. Standard PPI, clarithromycin, triple therapy should no longer be used as your first shot, period. It's the official abandonment of a long-standing protocol.
Wow. That's a huge shift. So for the learner, what is the new default? What takes its place?
The new preferred first-line choice is Bismuth quadruple therapy, or BQT, and it's given for 14 days.
Quadruple. 4 drugs.
4 components. A PPI, bismuth, tetracycline, and metronidazole. And that bismuth, surprisingly, plays a key role. It helps disrupt the bacterial biofilm and makes the antibiotics more effective against resistant strains.
That sounds like a heavy lifting regimen. How does compliance look with 4 different drugs for 2 weeks?
It is complex, and compliance is a real challenge, no question. But the data shows it works. And right now, efficacy has to trump complexity. And the data is also extremely clear on one technical point you cannot ignore. When prescribing BQT, you cannot substitute doxycycline for tetracycline. The medical sources really emphasize that doxycycline just has lower efficacy in this specific combination.
Okay. And looking ahead, there's a new class of acid suppressant that's emerging that might simplify things.
That's the most exciting development. It's a drug called vonoprazan, which belongs to a class called PCAIDs, potassium competitive acid blockers.
PCAs. How do they work differently from a PPI?
Think of traditional PPIs as slowly closing a tap on the acid pump. Vonoprazan rapidly clamps down hard on that pump and keeps it closed more effectively, no matter when the patient takes the pill.
A faster, harder acid blocker.
Exactly. And its superior acid suppression allows for a new, highly promising regimen. Vonoprazan amoxicillin dual therapy for 14 days. Just 2 drugs. It reduces the pill burden a lot while keeping efficacy high.
So whether it's the Bismuth quad or the vonoprazan dual, this is an intense course. What's the mandatory follow-up?
This is completely non-negotiable in the new guidelines. Proof of eradication is mandatory for everyone, and we no longer rely on, say, serologic blood tests, which can stay positive long after the bug is gone.
So what's the right test?
The confirmation has to be done using non-serologic tests, specifically the urea breath test or the fecal antigen test.
And there's a timing issue here that is crucial for anyone prescribed this.
Yes. The test must be done at least 4 weeks after you stop antibiotics, and critically, at least 2 weeks after you stop the PPIs or PCEs. Those acid suppressants can mask the bacteria, giving you a false negative.
What if you need relief during those 2 weeks?
You can use an H2RA, like famotidine, that won't interfere with the accuracy of the test.
Okay, we've covered the bacterial revolution. Let's spend some time on the other great culprit, NSAIDs. How does a simple pain pill cause such deep, dangerous damage?
It all comes down to a conflict over 2 specific enzymes, the cyclic oxygenase enzymes. You know them as COX enzymes.
COX-1 and COX-2.
Right. Traditional non-selective NSAIDs like ibuprofen or naproxen, they inhibit both COX-1 and COX-2. And that's the trade-off.
Explain that trade-off.
Well, COX-2 is the enzyme that drives inflammation, so blocking it stops the pain. That's good. But COX-1 is the principal enzyme responsible for mucosal cytoprotection. It creates prostaglandins that protect the stomach lining from acid.
So when you take an NSAI, you're removing the stomach's natural protective shield.
You are. You're leaving the wall completely vulnerable to the acid that's always there.
So the pharmaceutical solution was to create selective NSAIDs, or coxibs like celecoxib, that only target COX-2. How did that work out?
Very well at first. In terms of GI protection, the coxibs decreased the rate of visible ulcers by about 75%. But this surgical precision created a far, far greater problem, the cardiovascular trade-off.
Right. This led to some major headline-grabbing drug withdrawals.
It did. The early highly selective coxibs, like rofecoxib, Vioxx, and valdecoxib, were pulled from the market because clinical trials showed a frightening 2-fold increase in serious cardiovascular complications.
Heart attack, stroke, death.
Exactly. It created a massive crisis of confidence.
So why did a drug for pain suddenly cause heart attacks? What's the mechanism?
The leading hypothesis centers on the chemical balance in your vascular system. Selectively inhibiting COX-2 reduces the production of vascular prostacyclin, which is a compound that's essential for keeping blood vessels relaxed and preventing platelets from clumping together.
So you're shifting the balance toward clotting.
Dramatically. You're enhancing platelet adhesion, making it easier for dangerous clots to form, which can lead to a heart attack or a stroke.
That is an astonishing consequence. So what's the clinical takeaway today? Are all coxibs still considered dangerous?
The current thinking is that the risk is very dose-dependent and drug-specific. Celecoxib, which is less selective than the drugs that were withdrawn, does not seem to show a higher cardiovascular risk than the old traditional NSAIDs, at least at recommended doses.
So there's some benefit there.
There is, and one large trial actually associated celecoxib with a 30% reduction in serious GI events compared to the non-selective options. But the underlying risk of all common NSAIDs remains.
Especially when you add in low-dose aspirin for cardiac protection.
Absolutely. Even low-dose aspirin by itself leads to a 2-fold increased risk of GI bleeding. When a patient combines low-dose aspirin with any other NSAID, even one you grab off the shelf, the risk of ulcer complications can increase up to 10 times. It's an incredibly delicate balance.
This has been a true deep dive. The key findings for you, the learner, are that ulcers are often silent, the treatment landscape has been revolutionized, and the NSAIDs you take have a significant documented cardiovascular trade-off.
And tying this back to the treatment revolution, the new guidelines also expand who should be tested. It's not just for active ulcers anymore. Testing for H. pylori is now explicitly recommended for gastric cancer prevention in people with precancerous conditions.
And for family members.
Yes, also for first-degree relatives of gastric cancer patients. And this is a big step. The guidelines now also recommend testing household members of infected adults.
To prevent reinfection and spread.
Exactly. It moves H. pylori management into more of a communal health strategy.
That is knowledge worth having. So here is the final provocative thought we want to leave you with. Considering the high rate of silent ulcers and the fact that an untreated H. pylori infection can triple the risk from NSAIDs, what responsibility do we now have as consumers and patients to ask about the hidden, potentially lethal risks associated with common over-the-counter pain medications, especially when we might be carrying an unknown underlying bacterial infection? The time for assuming ibuprofen is completely harmless is over. This silent burn demands our attention.